Welcome in. I'm Collette Wieland alongside Dr. Stephen Camarata. Steve, as many of you probably know, is an author, an expert on speech and language disorders. He's a late talker and also the parent of a late talker. I think you're a little qualified to talk here today.
In some ways. I'm also a speech nerd for today.
Well, today we're going to ask you, pick your brain on the topic of labels, specifically today, talking about common labels regarding speech sound disorders. So what does that mean? What does that label entail?
So one of the things that's always interesting to me, and it's because of the kind of our background and the technical skills that we have, we would never conflate speech and language. They're two different things. So, but for many people, if I say speech, then they think about not only speech pronunciation, which is what I'm talking about, and rules for sound production, speech sound production. But often people, when I say, speaking, like some people say late speaking children instead of late talking children, and so they don't necessarily differentiate. So I want to put a pin in it today right away. I'm talking about pronunciation, how the child sounds when they talk. So I'm not talking about vocabulary. I'm not talking about complex sentences. I'm not talking about social interaction. I'll talk a little bit about how speech sound problems affect social interaction, but I'm separating this specifically to talk about pronunciation and speech production.
So using the word ball, so a speech sound ball or ba, like that
right,
kind of?
Yeah, so the word ball has what we call phonemes, 3 phonemes, ba, ah, o, and you put those together, and I'm in a way, I even regret saying that because some people then draw each of those segments, which you shouldn't do with a toddler, but anyway, setting that aside, if I say the word ba, I had a speech error. Now, it's normal for a 2-year-old to say ba for ball. So part of what we're going to talk about is when speech sounds come in and when it actually is something you need to worry about. Okay. But, from a technical standpoint, as an adult, if I say ba for ball, that means I have a speech disorder. I got the word right. The vocabulary word is correct, but I didn't pronounce it correctly, and that would be a speech disorder.
So parents may hear the terms organic speech sound disorders and functional speech sound disorders. So what's the difference between those
Good
two?
for you for finding that. Well done. I compliment you on your background reading. I did not tell her that. She found that on her own. So organic means that there's actually a physiological cause. So, for example, someone with a cleft palate. So the palate can form where there's a hole in the bone or the soft palate in the back of your mouth. And when that happens, you can't make sounds through your mouth. Okay, and what I mean by that is like a B sound is made speaking through your mouth. A child with a cleft palate, if they make a B, they'll go because they can't seal off their nasal cavity from the oral cavity. That's an organic speech disorder because there's a specific cause. Someone who has cerebral palsy, they're going to have a speech condition called dysarthria, which is pronunciation due to muscle and coordination. The cerebral palsy is an organic reason why they have the speech disorder. Most children, we don't have an organic cause, so we call those functional. It's a little bit misleading because historically functional versus organic was something that was used in psychology, and it really related to psychological problems. We don't think of speech as a psychological problem, but that idea of functional where we don't have an organic cause is what we're using for that. So if someone has a functional speech disorder, sometimes people call it. So articulation is the study of how the tongue moves and the lips move and so on. So people might say functional articulation disorder, and that just means we don't have an organic cause.
So you've kind of touched on this, but I want to kind of elaborate based on the research that I did. So with the organic motor neurological disorders, structural abnormalities, and then sensory perceptual disorders, right?
Right. Yeah. So we've already kind of talked about motor, which is like if someone has cerebral palsy, they have this general motor disorder, which affects speech, because speech is one of the most complicated motor things we do. And then structural is like if they have a cleft palate, or like if a child has their front teeth missing, when they try to make a T sound or a TH sound, they may end up with a lisp of that kind because that'll change when the teeth come in, things like that. Sensory or perceptual, I want to be really careful here. So that really is, for example, hearing loss. So one of our studies of hearing loss that we're working on now, speech nerd, they're having trouble with distinguishing production of M and N. M sound and N sound, which is really interesting to me for lots of reasons. But anyway, it's clear their hearing loss is why they have that. It's not because of a motor problem. So the B sound and the D sound are made in exactly the same place in the mouth as the M sound and the N sound. That's articulation. And so it's not a structural problem. It's not a motor problem. They can do the gesture. It's that something about their hearing, they're misperceiving the M and the N sound, and then that's causing that speech disorder. But we don't think of it as functional because it's secondary to their hearing loss.
Because it's organic, right?
It's organic because these kids have a severe, profound hearing loss.
Okay, so and then with functional speech sound, the articulation and phonological disorders, what is this more specifically about? Fronting, stopping, what is that?
Yeah, so I don't really like to use those very much.
Okay.
So we'll talk a little bit about it.
What do you mean you don't like to use the words or just examples of the?
So when people are doing analysis of speech errors, what I recommend is looking at individual phonemes and then targeting those individual phonemes. Now, what I mean by that is, so phoneme is the minimal unit of speech that's meaningful. So the word bat and the word mat are different because the B and the M are different phonemes. Okay. And so some people might say, oh gosh, B and M are both made in the front with their lips. So if there's an error in that, we might call that a phonological error because there's more than one sound affected. But a lot of studies show it's just better to target individual sounds. And so you can talk about patterns of sound change. Like some children might say, goggy for doggy, okay? And so what they're doing is they're what's called
cute, right?
It's cute, yeah. Well, I mean, all this stuff.
Right?
So all these things, all the functional articulation errors, they happen in typical development. It's just children outgrow them, And it's really fascinating because like a toddler's oral cavity is different than adults. So they make sounds that adults cannot make, and some sounds that adults make, they can't make. And so just because of the oral architecture and the structure of their mouth and the angle of their soft palate and how high their larynx is relative to that soft palate. So they can do stuff that, would be very bad for us to even try to do, which is fun. I enjoy listening to that. But anyway, it's cute in a toddler, and once a person gets to a certain age, then you really don't expect them to make that.
Right.
Right.
So what age is that? Because you said it's hard to distinguish normal development.
Yeah. Well, it's not hard for somebody that knows. We have very good data on when speech sounds come in, when they're mastered, and we've known that. And those norms have been very steady for more than half a century. So we know when sounds come in and when they develop.
And there's something about that preschool age that they have trouble with, the R's, ST. Which ones?
So R's and L's, S's, T's should be in by then. Those are all actually can be problematic into early school age, and it's not necessarily a problem. So the criteria we used were developed by Mildred Teplin in the 1950s. It was her doctoral dissertation, and I'm happy to say that we had a lot of women in science. One of the first PhDs that was awarded in speech pathology was to Mildred Berry in the 1920s. So we've been on the forefront of that, which obviously as a male, don't fit that, but. Anyway, Mildred Teplin was one of our really great scientists, and she did norms, and those norms have really held up. And so, for example, the TH sound, we don't expect children to master that until they're really 7 or 8 years old. Okay. So we would expect a 3 or 4 year old or a 5 year old to have a problem with that. R's and L's are the most common speech problem that people have. They're a little hard to make. And those also are mastered at around 6 to 7 years, so they're late emerging sounds. My colleague Ken Blyle actually has, the early 8, the mid 8, and the late 8 as far as dividing the speech sounds, the consonant speech sounds into different categories. And so a speech pathologist should absolutely be able to tell you where your child falls if you're worried about it. I kind of want to step back, though, and talk globally. So I tend to put speech sound disorders into 2 different categories. And what I talk about is speech comprehensibility or speech intelligibility, which is when your child talks, how much can you understand them, okay? Versus an articulation error where you can understand what they say, but it sounds funny. All right, so when Elmer Fudd says, you wascally wabbit, he has articulation errors. And Mel Brank was a genius in terms of portraying speech disorder as cartoon characters, which we can argue about whether we should be doing that in today's world. But anyway, it's a way to kind of look at those all cartoon characters. He was quite good at it. But if I said, at it like that, instead of wascally wabbit, you wouldn't understand it. You understood wascally wabbit because he did a W for R substitution.
An exaggeration of the word, right?
Well, when they leave off enough speech sounds, or another thing is when they make vowel errors. So if children make errors with vowels, normally vowels come in early and they're accurate. So a lot of speech pathologists won't even test them. But if they make vowel errors, it's devastating to that comprehensibility or intelligibility. So the idea is that you kind of want to have two levels as a speech pathologist, and in terms of how you work with the child, you want to say, okay, is this an issue where it's pronunciation, articulation, where you understand what they say, and I'm just trying to have them like fix a W or improve a W for R substitution like Elmer Fudd had? Or is it that, they're missing so many sounds that we just have to build overall comprehensibility or intelligibility? Those are two very different things, and we want to think about it. Now, the reason that's important is that I understand why people believe this. It's totally logical. But if you work on individual speech sounds, when a child has intelligibility problems, it won't necessarily improve their intelligibility. And it's kind of counterintuitive because you think about all these different pieces that go into all these little bits of sound that go into a word. Earlier I talked about all, and you'd think, if I make an L sound better, then I can understand it. But the reality is that there's a process where the child needs to learn how to make better sounding errors so you can understand them better. So let's think about it from an intelligibility standpoint. So if I say the word row for roll, you're likely to understand it. But if I say ol for roll, you're not going to understand it, even though the number of consonants that are wrong is the same. And so this idea of consonants necessarily driving intelligibility doesn't hold up. And it's interesting because in the adult interventions, like people have ALS or Parkinson's where they have these motor disorders, people don't work on speech sounds. They work on improving overall intelligibility or comprehensibility. We actually need to do that with our children if they have severe speech disorder. And so I don't know if this is confusing, but I'm trying to distinguish the two areas.
It's just a lot of information.
That's why I'm a speech nerd, yeah. And I mean, like language disorders, I know a lot lot this.
Well, let's break this down. Okay, so let's start with signs, right? Okay, yeah. You don't know if your child has a speech sound disorder. What are some of the common signs you see? Yeah,
so basically what we're doing there is we're listening for how they say words, or if they're not saying words yet and late talking, we're listening for their vocalizations. So we have this pre-speech kind of thing called babbling. And it sounds like speech, and they're using speech sounds in there, but it doesn't necessarily have meaning. And all children go through babbling at around 6 months. But if I'm listening in a late talker and they're not babbling, or they're only babbling using, say, vowel sounds, then I'm kind of suspicious that a speech disorder is on the table here. When they start using words, it's just really clear. If they're leaving off sounds, if their vowel sounds are really not anywhere near the target, then that's going to be a sign of a speech disorder. You'll see secondary signs if it's a motor speech problem, like groping. You'll see kind of a general incoordination. You might see drooling. There's things you're looking for to see if it's more of an organic motor speech versus a functional speech problem.
What about diagnosing? How long does that typically take, and how many evaluations?
You should be able to do it within the first visit.
Okay.
Yeah, and in fact, when I get a video, if the sound quality is good, I'll already have that on my radar, and then I'll be.
Well, that's because you're a speech nerd, but what?
Yeah, but everybody should.
Okay.
In other words, everybody should be thinking about. In fact, I'm working with a group of developmental pediatricians to develop a checklist, and we've made sure there's items about speech understanding your how when your child speaks, understanding them is now on that chart because it needs to be. So no, you're listening for, if a child says, mama, dada, and things like that when they're a toddler, then you would expect that. But if they're saying no consonants, well, maybe there's speech in here. Maybe speech is involved. So it's very noticeable. I'll just say it that way. If you're listening for it.
What does the intervention look like in treatment?
Super important question. So we know that if you're working with Elmer Fudd, who says wascally wabbit, and he's at least school age. I think Elmer Fudd might be middle age or beyond. And why he's hunting the wascally rabbit is another topic. We won't endorse that. But anyway, you can sit down with Elmer Fudd and you can say, okay, look, you're doing a W for R. You can give him strategies on how to make an R sound. You can't do that with a toddler or a preschooler, but because a lot of clinicians learned how to do this drill-based articulation, they try to do that with preschoolers, and that's really not what should be done. So when someone, and this is our area of research, the first article I published on this was back in the early 90s, and it's something that's really held up well. Actually was recently updated in like last year in a big textbook. So the idea is that basically what you want to do is when the child touches an object or when they say a word, you just want to say it back to them. It's like a mockingbird game. And the idea there is you're giving them the auditory input to start matching their pronunciation to what the adult model is. Now, what's really cool is that this is also seen in primates. So this is hardwired into human behavior. So you have these little baby marmosets, and they make like they sound like bird calls. And then the little mommy marmoset says it back to them and modifies it. So we call it speech recast, and it's really what you should do with a toddler or a preschooler. It should be very word-based. We call it lexical-based. So it's word-based. It's not individual speech sound-based. We're going to do that later when the child's older, and you can actually work on individual speech sounds. I have seen people sit down with a toddler and try and drill them, for example, on how to do an S sound. Man, that's just really not something I would really recommend. And I'm not the only one. There's other people who kind of promote this for preschoolers and toddlers. Once a child gets out of that phase, then you can work on what we call articulation training and do the cleanup for the individual speech sounds. And that's kind of the progression. There's also a lot of people that might, for example, have the children like blow in whistles, blow bubbles. They might do like different like vibrating things on their mouth or their tongue to increase sensitivity. There's people who might do strength exercises. None of those things should be used
for a speech sound.
For speech sound disorder, no. I'm not going to say anything, but that should never be done for any kind of speech related work. One of the most tragic things I've seen, and people can go and find it, is there's a little Down syndrome boy in a little preschooler, such a sweet little guy, and the person working with him is having him bite down on a bite block, a chew toy, and it's hard, and she's having him count, and he just starts crying, And this masseter is one of the strongest muscles in our body, and if the child can chew, that's way more strength than you need in order to make speech. So the whole idea that this little guy, and he's just crying, you just see these tears rolling down his face. Yeah, it just tears my heart out. It makes me upset, actually. It's like, why is this person doing to this child? Because the whole idea is completely misguided. The amount of strength needed for making speech sounds is very minimal. It's not really a strength issue, but there are a lot of people who might push that, and blowing bubbles, blowing different whistles and so on. It's just not an efficacious way to do it. I remember when I was in school, I was taught when I was a undergraduate, I was taught to put these little sticks on the child's tongue, that had little like star shapes and triangles and so on. And even then you might suspect I was a bit skeptical and look for evidence on that. But the idea was trying to sensitize the tongue to touch, and that would help. And of course it doesn't. It's been around for a long time.
Is a speech sound disorder something that you can fix?
Absolutely. Yeah. Okay. Like our studies have whopper effects, like big effect sizes. Oh yeah, you can totally improve speech. Like it's one of the most, robust findings across the whole age span. There are certain things you can do to improve speech comprehensibility, intelligibility. We have a big study we published on Down syndrome that these lexical recasts improve that in Down syndrome. And then, for any kind of speech disorder, we can absolutely improve speech production.
So if you're a child who has a speech sound disorder, is it something you're going to have to get treatment your whole life, or do you?
Normally not. So there are severe speech disorders such as apraxia. By the way, some clinicians use apraxia for all speech disorders. That's not what you should do. It's a very specific motor speech disorder that we talked about in a previous visit, but I'll just say once again, it's a severe speech disorder where there's evidence that they can do the motor activity, but it's a motor planning problem. Excuse me. Sorry.
See, he got so excited talking about speech disorder.
Right, yeah, so that was organic. That was an organic speech problem there with my voice. So basically for apraxia, they show you they can make the speech sound sometimes, but they can't make it other times, and it's usually on demand. So if you say, like the child, you might walk in and the child's playing with a ball, and then you might say hi, and then they might look up at you and say ball, and then a little bit later on you hold the ball up and say ball, and then they go boo, boo. They can't do it. They grope, and that's really what apraxia is. And we can improve that, but for some children with apraxia, they never really acquire the ability to speak verbally, and so we have to use a computer or some other way to help them teach us. That's called augmentative communication.
Steve, next week we're going to talk about ADHD, a label often associated with speech and language delays. In the meantime, please check out the other podcasts that we've done, especially this little set here on labels, and then join us next week. You can also drop questions, anything you have on your mind, comments, questions, put them below. Click subscribe so we can keep getting information your way. Hit the bell. And of course, please check out the Late Talkers Foundation website.
And remember, the best thing for your child is you.